Thank you very much, and thanks for having us today. So I'm Josh Lynch. I'm an ER doc in Buffalo, and really try to work hard to link patients up to treatment that can't get linked any other way. So I was originally asked to talk about fentanyl, and a few months had gone by, and we really can't just talk about fentanyl. We need to talk about xylazine too, and I think we really need to talk kind of equally about these two problems. We've had some time, unfortunately, to learn about fentanyl. It's been on the news. Xylazine's been on the news too, but admittedly, it's been less described in the news, and it's also been less described to the medical community because human doctors don't know much about it. Veterinarians know a lot about it because it's a medication that's used for large animals. So we'll talk a little bit about that as well. Just a couple disclosures. I helped Emergent Biosolutions with their Narcan over-the-counter approval with the FDA a few months ago, and I have helped in the past Gilead Sciences link patients up for treatment for hepatitis C. Both are obviously important projects. We have a fantastic team. Many of them are here. If you guys can just raise your hands. I certainly can't do any of this by myself. And so big shout out to them for working very hard every day and some nights and weekends helping to carry out our mission. I wanted to start off and ask everybody to think a little bit about why do we need to have a talk like this for opiate use disorder and substance use disorder. There's not a talk about linking patients to care for chest pain or strokes. That's on the news. People are tripping over themselves to get patients linked up for stroke care. How many billboards do you see about get to this hospital for your stroke care, get to this hospital for your cardiovascular disease, get here for your cancer treatment? All of those things are serious diagnoses, but you don't necessarily see the same approach taken with substance use disorder. So why is it so hard, and why hasn't the medical community figured that out? So I work in the ER, and arguably that's the front door of the medical system for many patients struggling with substance use disorder and or mental health diagnoses. If you have both, the cards are really stacked against you in regards to getting treatment. So in the emergency department, we see everything and anything all day and all night. And the way that we have, for a very long time, approached linking patients to treatment for substance use disorder is just this: handing someone a piece of paper with their discharge instructions with some phone numbers on it and saying, good luck, here's some numbers, they're all going to take care of you, they'll all get you in tomorrow. And we've known for a long time that most of those papers either end up in the garbage, or if someone takes it home and calls one of the numbers, maybe they don't answer, maybe the number's wrong, and chances of getting an appointment tomorrow if you call a number off the street is pretty darn low. So if somebody is lucky enough to bring the paper home and they call a number and it doesn't work, what do you think the chances that they're going to try another number? Probably zero. So taking someone who probably feels isolated and alone with substance use disorder or mental health, or both, and giving them that experience of coming to the hospital, not the perception of not doing much in the ER, and giving them a list of numbers that don't work. I would argue that for a long time, experiencing the ER for a patient with substance use disorder or mental health makes it worse. And it certainly makes them feel more alone. And I think another part of the reason why substance use disorder or mental health isn't as clear-cut as a stroke or a heart attack, those things are easy for me to treat, easy. We know what to do, we know the treatment, we know who the specialist is, they're willing to come down, and at times they literally trip over themselves to come down and take care of a heart attack, which is obviously what we want to have happen, right? But addiction is an easy problem to put on the back burner. It's really easy actually to do that. It's in some ways an unsolvable problem, a problem that is hard for people to figure out where to start. So if you went to a hospital that wasn't doing anything for patients with addiction, and you said, hey, where are you going to start? We're going to try to treat patients with addiction and substance use disorder better. Where would we start? That's a hard question to answer. It's a hard question to answer. This is a picture, an accurate representation of an actual thing. Who knows what this might represent? What's that? A methadone clinic. That's exactly what this is. You see people that are standing in presumably the rain with cameras out front in a not big enough sidewalk. Back to other medical problems. If we made patients wait for a cardiologist office like this, society would lose their mind. Absolutely lose their mind. So this is another, methadone is a tool, a very powerful and successful tool to treat opiate use disorder, but here's what you got to do to get there. It doesn't take long to figure out that you need a new idea. And we'll talk a little bit more about this later, but that's what me and my team do. We try to create new ideas every day, and we try to make the slides that I just showed you be things of the past. So how did we get in this mess? Aggressive prescribing of opioids really is part of the problem, part of the beginning of the problem for many, many patients. And that can happen after an innocent injury like a rotator cuff problem, wisdom teeth extraction, an ACL surgery. Making that, kind of compounding on that, years of miseducation to physicians about the lack of addictive properties of opioids certainly contributed. There was, for a long time, physicians are responsible to maintain patient satisfaction scores. It's like when you get a car, they say, please fill out all 5s when you get our survey. Same thing is in place for hospitals, doctors' offices, et cetera. And one of the questions was, how well was your pain treated? That question is now gone. It's obviously important to treat people's pain appropriately, right? But when you tie patients' responses to that, to financial reimbursements to the hospital, the whole ballgame changes. So now hospitals had money at stake in regards to how patients perceived their pain being treated. So that increased the amount of opioid pain medication that was given during hospitalization and after discharge. Now, I think in some cases, maybe that pendulum has swung a little far, and some people are really pushed and pain medication may be withheld for very painful conditions, but it's something that, it's a consideration to make. So to compound on that even more, fentanyl and other drugs have higher potency. They require more frequent use. This kind of ties back to the business of drug dealing. You want something that's stronger, more addictive, requires more frequent use. But other challenges that are talked about less are things like more frequent use means more needles used, which means harder to access clean supplies because you need more supplies. And other drugs can be introduced to help increase the effects of the drug that someone might be using. This room seems like a pretty connected room to the substance use disorder community, so this slide is probably not a surprise to anyone, although it's incredibly disappointing. So Erie County is not doing so great. What we thought we were heading in a good direction in about 2017 and 18 when the numbers were continuing to go down. And then a new period of isolation, unlike we've ever seen before, with COVID shutdowns, drove opioid and substance use to levels much higher than the system could handle. And oh, by the way, you couldn't go to most clinics because they were closed too. And access to methadone was completely thrown for a loop for a long period of time, like social distancing in the lines. So imagine the line we saw with the people with the umbrellas spread out one person every 6 feet. The people would be a mile down the street. And many patients at that point decided it wasn't worth going to the clinics to appointments, and they would use alone, and they did not have anyone to call 911 or to resuscitate them with Narcan, and a lot of people died. The continuation of the curve going up is really multifactorial. It's partially reflective of the prevalence of fentanyl, but now also the addition of xylazine into the drug supply makes it harder to resuscitate somebody. There's more factors that we'll talk about in a little bit. Fentanyl introduction into the cocaine supply has also caused considerable problems. There are many patients that come into the emergency department that were unconscious and received Narcan, and they came in and we told them that they had an opioid overdose, and they said, "There's no way I had an opioid overdose. I only use cocaine." Well, what they didn't know is for the previous few months, while they were using cocaine, they were developing an opiate addiction that they never even knew was happening. So for patients to face the reality that now they have a cocaine addiction that they knew about and an opiate addiction that in many cases could be a fatal diagnosis, that's a heavy pill to swallow when you're in the ER and you're telling somebody this for the first time. Almost as hard as telling someone about a cancer diagnosis. So as you can see, there are many, many drug deaths with fentanyl and opioid combined. Fentanyl and cocaine combined. One other measure of how we're doing, there had been CDC statistics that I think were pretty widely publicized. About 1 in 10 patients were actually able to get treatment. Luckily, that is now around the 20% range. I just realized I said luckily it's around the 20% range, which sounds completely unacceptable, and it still is. We're heading in the right direction, but we still have a long way to go. A long way to go. I wanted to take just a minute to clarify the difference between opiate use disorder, which is a term that's thrown around a lot, and dependence on opioids or chronic pain patients that take opioids every day. There's a line between being dependent on opioids and having opiate use disorder. And basically what you need is 2 categories present for a period of time. So if someone has tolerance to pain medication because they take it every day, and they have signs of withdrawal when they stop taking it, that's not opiate use disorder. That's dependence. So there are many people that take opioids every day for chronic pain that don't have opiate use disorder, but they are physically dependent on the medication. So if they just stop taking it, they go into withdrawal, they need it every day, they take it every day. If you introduce one of the other 2 sides, such as consequences. So patients that come into the ER after an overdose that have required 911 to be called, that have required Narcan, I don't need to look at this, they have opiate use disorder. There was a degree of tolerance, and they had hazardous use. Hazardous use, I would certainly qualify as requiring Narcan and 911 to be called. On the other side, loss of control, I mean, that certainly could play into someone who has an overdose that requires 911 to be called, that requires Narcan. But patients who change their lifestyle to support drug use and income to continue drug use, I would argue, are exhibiting a loss of control. The take-home message about what is opiate use disorder is that opiate use disorder has now been clearly defined by the evidence as a chronic disease that is severe and life-threatening. So that actually should make it easier for the medical community, because we know how to treat severe life-threatening diseases, right? I mean, that's what many of us do every day. And I personally, when I see someone with opiate use disorder, someone after an overdose, just saw someone yesterday afternoon in the ER where I was working, I drop everything like I would drop everything for someone else with a severe life-threatening disease. Any questions so far before we switch gears and talk a little bit about fentanyl? Excellent. So fentanyl is a manufactured opioid. There has been fentanyl circulating around for many, many years. It had never gotten to the degree of potency and the degree of prevalence in the drug supply until recently, where we've started to hear about it in the news and we've started to see it show up on toxicology screens or through autopsy toxicology information to the prevalence of where it is now. So the high potency is attractive to people who are distributing drugs because it can be a smaller quantity can be cut apart with other substances, providing the same amount of material or drug to someone, but they're actually using much less supply, so it increases their profits. For someone who's been selling drugs for a very long time, this is actually something that they want to do because it makes them more money. And fentanyl for a long time, but again, we're seeing it much more over the last few years. It's been mixed with other drugs for quite a while. You saw the slide on cocaine and fentanyl mixed together. There's really minimal to no just heroin overdose deaths anymore in Western New York. It takes about that much concentrated fentanyl to cause someone to completely stop breathing, an average size adult. So that little bit of fentanyl mixed with other things can increase the size of the drug quantity that you're using, but that at the end of the day is really what you need. There are other formulations of fentanyl that are more concentrated than regular fentanyl as we know it. They're formulations typically utilized in the veterinary space as well, so they don't have to give an animal a huge volume of medication to get pain control. However, that level of concentration of fentanyl exposed to a human is obviously extremely dangerous and never intended. Not all fentanyl is bad, though. We use fentanyl in the hospital, on the ambulance, every single day. It's actually a fantastic pain medication when used in the right quantity, when used in the right dosage, and when used when you know it's pure. So we're using doses of 25 micrograms or 50 micrograms, which is a normal dose to treat pain, or 100 micrograms to cause some sedation for like a painful procedure. This fentanyl that you find on the street doesn't come from the drug company. It comes from who knows where, and it can be mixed with other things. It's certainly not regulated, and the doses are often magnitudes higher than what we would use in the hospital for appropriate treatment of pain. But it's actually a preferred pain medication to use in the hospital, especially in the emergency department when someone has a painful injury, they break their femur. It frankly works better than morphine. It works better than Dilaudid. Those are other concentrated opioid pain medications that we use in the hospital all the time. So there's a difference. I just wanted to make sure people knew that. There are still some patients that I see on a relatively frequent basis that when I tell them we're going to give them fentanyl for their pain, they say no thanks. So we have a little discussion just like we had now in the ER next to the patient saying, the stuff we're using is safe, I know what I'm doing, and we're going to give you the appropriate dose that's going to make you feel better. This isn't going to turn into a chemistry class. The middle structure is fentanyl. So I had talked a little bit about some of the concentrated forms of fentanyl that's used in the veterinary space, or sometimes we use a concentrated form in the pediatric or neonate population where you don't want to have a large volume of liquid going in to those patients because they're so tiny and cute. But what happens with fentanyl is that it's actually very easy to change the chemical structure. You don't need a huge sophisticated lab to do that. And that's a problem for really two reasons. One, it can change the potency without any quality controls. But what it also can do is change the chemical structure into a structure that's not technically illegal. So changing to a new analog of fentanyl by just switching up some of these groups can technically let people skirt the legal system by having something that's not on the list of scheduled drugs. That's I think a fact that's a little less known, but also contributes to the problem being worse. So the DEA needs to keep up with finding these new formulations scheduling them so they actually can prosecute people that have the possession of this, that are selling it. Narcan or naloxone works on fentanyl, period. It works on all formulations of fentanyl. It may work better on the less concentrated forms and may take higher doses of naloxone to resume normal respirations and level of consciousness in patients that have had more concentrated forms of fentanyl, but it works on fentanyl. So naloxone-proof fentanyl that you may see on the news is really not a thing. It may take frequent dosing to have an affected response, but there's not. Fentanyl is an opioid. I'm going to show you how naloxone works, and it works. There has been this hysteria created in the news and on social media about fentanyl and first responders and people going unconscious by being in a room with fentanyl that's on that table. And many of us in the medical community just don't understand why this continues to keep going. But I'm going to share with you how this actually can be incredibly dangerous and make the problem even worse by this kind of false media reporting continuing. I was looking online or at a store or something, and I saw fentanyl-proof nitrile gloves. Nitrile gloves are the blue ones that we use in the hospital. They're all fentanyl-proof gloves. And do you think the fentanyl-proof gloves were cheaper or more expensive than the regular gloves? Things like this is what keeps me up at night and makes my blood pressure go up. There are companies that are trying to take advantage of public fear that is created by the media and other groups of people and capitalize on them. So some of my colleagues from across the country are also very aggravated about this, and they actually looked at a bunch of news articles across most of the country in how big of a problem really is this. So in their paper, you can Google it, they looked at over 500 news articles. They saw that there were almost 500,000 Facebook shares, and they estimated that reached about 70 million people in 4 years. If we could have good news articles reach this many people in 4 years, I think we'd all be in a much better place. So why this matters? There are many cases of dispatchers telling police officers, don't go into the scene, there's fentanyl there, you have to wait for decontamination to happen. So that could happen whether there is a law enforcement problem taking place. Now you're delaying the people who need to get in there to fix the problem. Or it can be on the other end of the spectrum, someone could need naloxone and they're in a house with who knows how much fentanyl. It's not just aerosolizing and filling the room. And now first responders like EMTs and paramedics and firefighters aren't going in because of the hysterics that have been created, thinking that they're going to walk in the room and die immediately from inhaling fentanyl. It's just not the case. But these stories continue to happen and happen. This story was just from April 10th. If you accidentally touch fentanyl powder, just wash your hands. You won't be immediately incapacitated. You won't. You really won't. So if the take-home message here is that if you're in a room and there's fentanyl, hopefully you're not in that room, but if you're in the room and there's fentanyl on the desk, you're okay. Carrying naloxone, we have some here. If you haven't grabbed some, take some. There's going to be a couple slides on just a little bit of brief education, but it's very safe, and the over-the-counter labeling will make it even easier for people to use. We talked a little bit about forms of fentanyl are responsive to naloxone. Okay. Before we switch gears, again, any questions about fentanyl? If you don't ask now, you can ask later. Yes, ma'am. It doesn't go through the skin. I mean, you don't want to touch it and then put your fingers in your mouth, which you shouldn't do anyway.
And I had a question about the medical fentanyl. Is it as addictive as the street fentanyl?
Great question. So is fentanyl that's designed to use in a medical setting as addictive? So when we're treating painful conditions in the ER, we want to use the least possible dose to provide adequate pain control. So getting a couple doses of fentanyl in the emergency department will not cause you to be addicted. If you're in the hospital for a week and you're on a fentanyl drip continuously, that patients that are in the ICU that are sedated and have ongoing fentanyl drips, when they leave, they do have some issues with dependence. That doesn't mean they have opiate use disorder, right? Because they're not doing hazardous things and they're not losing control. But there are patients that have prolonged intensive care unit stays that are on fentanyl for many days or weeks. Sometimes those patients will go home on a methadone taper to slowly taper them off of the medication. Now, the ICU literature and practice is changing to minimize the use of opioids for patients that are sedated on a ventilator. There are other medications that we use that are not opioids because we understand the danger. Some patients are very challenging to keep sedated and comfortable while they're on the ventilator, so sometimes fentanyl does need to be used. Other analogs of medical fentanyl are used in the neonatal intensive care unit and the pediatric intensive care units of hospitals, primarily because of a volume and concentration and fluid issue. Good? Okay. So more attention in the last month has been brought to xylazine than I think probably has ever in the history of xylazine being around, which actually is a very long time in the veterinary space. So Senator Schumer was down the thruway recently and wanted to direct more funds into New York State to try to increase detection, decrease supply, increase access to treatment, and provide public education on what xylazine is, why it's dangerous, why it matters. Another word for xylazine is tranq, and that's really more circulated, I think, around like the Philadelphia, Camden area. But it's a veterinary medication that's actually been around for a long time. Interestingly enough, it had started as an antihypertensive medication. The problem was it was a little too potent, and patients' blood pressures dropped substantially, and mental status decreased. So it was the pursuit of FDA approval for humans was not the case, was not continued. But it was and it is approved for veterinary use. It's a sedative. It's a sedative used for large animals, like the horse's nose that you can see on here. It's meant for large animals. It's not meant, and it's not approved for people. So you might be thinking, and when I started learning about this, I was thinking the same thing, like, why is this happening? Why is it contaminating the drug supply? Who would want to be exposed to this medication that's never meant for humans and causes awful wounds and causes more sedation and increased rates of deaths? Xylazine has actually been in the heroin and fentanyl drug supply for many years. However, it never really was at the concentration that it was clinically relevant. So a little xylazine in heroin may not have mattered clinically. It clearly didn't matter enough or caused enough separate problems to get on the radar of drug detection devices, the medical community, law enforcement. But now, fentanyl has become so concentrated that the addition of xylazine draws out the effects of fentanyl. So if people had been using heroin, they were used to a period of euphoria that lasted this long. And now those people or new drug users are using fentanyl and the effects are this long. So they may be using at 1.5 times the frequency over the course of a day than when they were before. So xylazine, in a way, extends that period of effect by adding some sedation to it and a little bit different form of euphoria. So to a patient, that may be desired in some cases, or to someone who's using fentanyl, that prolonged effect might be desired. To someone who's selling drugs, that product may appear as more sought after. Obviously, it's mostly not positive. We have seen this in the Northeast, and in particular in the Philadelphia, Camden, New Jersey area for several years. It's almost like a glacier that we knew was coming to the rest of the country is now coming to the rest of the country. The Southeast really has been the second spot where things are ramping up. In the Florida, Alabama, Mississippi area, they're seeing significant rises in this, and not necessarily Florida, but some of the other Gulf states or even in the panhandle of Florida, access to treatment is terrible. So we obviously have challenges around here. I spent some time in Alabama, and if you told anyone in Alabama about the treatment resources we have here, they would be incredibly jealous. So increasing xylazine supply and fatal overdoses in the Southeast is incredibly concerning to me because they just don't have the treatment capabilities that the rest of the country has. It's not like the rest of the country is doing great. Okay, I want to show you some wounds, just one slide of skin wounds from xylazine. So if you don't want to look away. The mechanism of why this happens is not completely understood. Injecting fentanyl with xylazine in it obviously causes the wounds, and that may be a little easier to understand medically, but there are also patients that are developing these wounds after they snort xylazine containing drugs, and we're not 100% certain why these still happen and why they happen in particular areas of the body after snorting xylazine. There's actually a lot of questions about xylazine that we don't have the answers to. Several of us were just in Washington, D.C. last week and in Atlanta earlier in the week for 2 national conferences on addiction, and no one seemed to have great answers about xylazine. There were a handful of presentations about it. They were helpful. We'll move on. They were helpful, but the take-home message was there's not a lot of answers. Yep.
Where are they getting the xylazine?
So I'll touch on it on the next slide. Thank you. Can you see this? We talked about xylazine prevalence in the Camden and Philadelphia area. We have colleagues in both of those cities that have told us for a while it will make its way up there, and it is awful. It is absolutely awful, and they're right. So in 2022, the 2022 data is not totally finalized from Erie County from the medical examiner's office, but 13 of the 298 so far overdoses have included xylazine in them. I would bet in 2023 that number is going to be much higher, much higher. So to your question about where xylazine comes from, we discussed xylazine being an FDA-approved, utilized medication in the veterinary space, and that is one way to get it. You can buy veterinary medications much easier than you can buy human medications. Just go to Tractor Supply. You can buy dewormer and anti-inflammatory medications, and there's much. Don't go to Tractor Supply and buy those things. Although I did try to buy ivermectin for one of our horses during COVID, and they wouldn't sell it to me. We'll move on. So the veterinary supply is one thing, but you can get it from China, and most of the illicit supply that is not veterinary use can be bought from China relatively easily, and it's relatively inexpensive. So I hope that answered your question. Probably not what you wanted to hear, but it's very easy. It's actually very easy to get your hands on.
So we can order the precursors and analogs from China for fentanyl as well as the xylazine.
Yeah, and that's why we're having this talk today. Part of the reason. Xylazine test strips are available. Certain states, they're available as of like a month ago. So this is very new technology. We're still kind of working out the kinks on how to best use the strips. And what I mean by that is we have a solid understanding of the dilution that needs to take place of a drug with water to have a reasonable, accurate, positive or negative result on a fentanyl test strip. We know for the most part how to dilute that. The early data that has come out on xylazine test strips is that they turn positive with very, very, very low concentrations of xylazine. Now you might say, well, why does that matter? Well, do you remember how we all became experts on rapid antigen testing and PCR testing over the last few years, right? I know my mom and dad think they are. So it matters. So with COVID testing, it mattered on how much viral load you had in your nose when you would do the test, if it was going to be positive or not. Similar case here. So the problem with them turning positive with such a tiny, clinically insignificant concentration of xylazine is that when we look at behaviors after you have a test that's positive, what do you do then? You're about to use drugs, you test the drug for fentanyl, it turns positive. What we, the medical community, hope that you do is either don't use it, probably rarely happens, use less, inject slower, and in all those cases, have someone with you that can call 911 and give you naloxone. So if you think about a test that almost always turns positive, the likelihood that behavior will change to a safer set of behaviors is much lower. We don't want it to turn negative when there's clinically significant xylazine present, but we also don't want it to turn positive every single time. So what do you do if you suspect an overdose with xylazine? You shouldn't worry if it's an overdose containing xylazine or not. You should do everything the same that we've been training the public for many years. Give naloxone, call 911, and wait with the patient. What we don't want to have happen is the naloxone is here, the unconscious person is here, the phone to call 911 is over there, and you're trying to investigate whether there's xylazine containing or not. We don't want that to happen. Just do everything the same way. Everything the same way. Now, xylazine is not an opioid, so naloxone does not reverse the effects of xylazine. However, most overdoses are not xylazine by themselves, and oftentimes the patient may be unconscious because of the fentanyl and not the xylazine. So if you give naloxone, there's a good chance that the patient's respiratory and level of consciousness status will get better. So what we don't want you to do is withhold naloxone thinking that you've solved the mystery and the patient doesn't have fentanyl on board. They almost always do. I'm going to talk a little. Oh, sorry. Was there a question? I'm going to talk a little bit about harm reduction, and harm reduction is an important concept that is now kind of becoming more mainstream. And so before we talk about harm reduction and drug use, we do things to reduce the potential for harm and injury every day. Hopefully you wear a helmet when you ride your bike or motorcycle. Hopefully you buckle your seatbelt when you're in a car. There's really no option on an airplane because you'll get harassed and they won't take off or close the forward boarding door until you buckle your seatbelt. So also sunscreen, wearing masks during the pandemic. We don't need to discuss the details of that harm reduction measure, but we all do things to reduce the potential for harm when we do activities every day. So if you think about harm reduction with substance use, it's the same thing, really is the same thing. And actually the consequences are much more important. So if you don't use harm reduction techniques, the potential adverse effect is death. There's really a couple main harm reduction approaches that that our program helps with and that are fairly available to the public, and that is drug testing devices like fentanyl test strips, naloxone that we've talked a lot about, harm reduction vending machines that haven't really become too popular in New York State. They are in other states. We're excited to be rolling out about a dozen of them later this year across the state, hopefully a couple locally. I'll tell you why. So naloxone, not to get too pharmacology on you, but there's the opioid receptor that drugs will hop on the opioid receptor and activate the receptor. So that will cause respiratory depression, pain relief in some cases when used appropriately, and also with too much can cause low blood pressure. When you add naloxone to the mix, the naloxone binds to the receptor very tightly and kicks the opioid off the receptor. So it kicks the opioid off the receptor, the opioid effect goes away, and the naloxone sits there and doesn't do anything, and basically inactivates or blocks the receptor. Make sense? So if you've taken something other than an opioid and you give naloxone, the naloxone will go to the to the opiate receptors, but doesn't do anything. So the take-home message about naloxone, we'll talk a little bit more about this later, is if you give naloxone to someone who's unconscious for a reason other than opioids, nothing happens. So it's safe. So if someone's unconscious because they are in a diabetic coma from hypoglycemia and you give them naloxone, it's fine. Nothing will happen. What we don't want you to do is say, I don't know why they're unconscious. I'm not 100% sure if they took something with opioids and then not give naloxone. Here's a picture of myself next to Julie from the vending machine company, and it's loaded with all kinds of things to attract people over to their booth at the conference, but these are what the machines will look like that will be spread around New York State. So fentanyl test strips, we talked a little bit about how they work. They're a true harm reduction strategy. You test the drugs. If there's fentanyl in it, we hope that you change your behavior or at least pick a little bit safer behavior. So having naloxone around, having someone around to call 911. So the Matters program distributes fentanyl test strips all across New York State, and we work with the State Department of Health, Office of Mental Health, and OASIS. We distribute to all of their clinics across the state. This is a picture from any given day in our office with fentanyl test strips that are ready to go out the door. Almost every fentanyl test strip that is mailed around to OASIS clinics or other places comes through our office right down the street. We have distributed almost 500,000 fentanyl test strips since August, September-ish across the state. A lot of those have gone to New York City. You can download the app and request free fentanyl test strips, or if you don't feel like doing that, just walk out the door. We would love to continue to grow this map and get more test strips into the hands of people that need them. If we ever talk again, what I would like to tell you is that we are hopefully distributing xylazine test strips, utilizing our infrastructure that we've already set up to get those into the hands of patients that need them too. So these are the total test strips. We can also mail strips directly to someone's address, P.O. box, a house, an apartment, their friend's house, whatever. So if you know of other organizations in other parts of the state or your organization or your friend's organization, we are happy and willing and want to send them fentanyl test strips too today. Sorry, Matters folks, if we get a ton of orders by tomorrow. But seriously, tell your friends. Any questions about just the quick overview of harm reductions? Yes, sir.
Going back to xylazine for one moment. Xylazine is showing up in fentanyl, and fentanyl is showing up in other drugs. Xylazine being created into what's other drugs.
Oh, absolutely. Absolutely.
The cocaine and press pills and things like that.
Yep, it depends where the cocaine and fentanyl is mixed. If it's mixed after the xylazine and fentanyl get together, then yes. But the possibility of that is absolutely present. You have a question? No? You have a question? Yep.
Yes. Does the removal of xylazine leave any withdrawal symptoms?
So, yep. Xylazine withdrawal is pretty terrible. And it actually is thought, so not something that we understand completely. We know that it's bad, and we also think that it happens before opiate withdrawal in the time frame. I don't have any more answers than that.
Is there an MAT for silence?
No.
Do you think it causes people to increase their fentanyl intake because they're feeling lousy from the xylazine withdrawal?
If I was in combined opioid and xylazine withdrawal, I would probably do whatever I could to get myself out of it. Hopefully, that would involve getting treatment or getting Suboxone or something somewhere to get myself out of withdrawal. But the short answer, I think, is yes. If the worse you feel, the more desperate you get to not feel so bad. Yep.
Going back to the skin, you said it typically appear on certain areas. Where are those areas?
The extremities. Yeah, the extremities, and unfortunately, those wounds progress so quickly that it often leads to amputation.
And how quickly does those wounds show up?
It depends. Okay. Oh, you took her question. All right.
Do you know like how they started hearing as far as like the staging of it?
Yeah, so I don't have that. I don't have that information in here, but typically what you see is some disruption in the skin at first, and then when the skin breaks down or breaks open, you are greeted with a nasty ulcer underneath. Not that much more advanced and quickly progressing than what you would see, if you scraped your arm and it got infected, which takes many, many days, and it doesn't, turn into what you saw up there. Those wounds can happen in a period of just a couple days. Yep. Do you have a question or stretching? Stretching, okay. Okay, so speaking of doing things that you can do to make yourself feel better and get yourself out of withdrawal, I thought we could spend a few minutes on looking at how to treat opiate use disorder and just run through and kind of level set about what MAT is. So MAT can be referred to as medication-assisted treatment. We are trying to kind of steer towards medication for addiction treatment because what we've learned is that the medications do the heavy lifting and actually do most of the work and aren't assisting. So medically assisted treatment is a little less relevant. It's really medication for addiction treatment or MOUD, medication for opiate use disorder. You can say it however you want. But there are also roles for counseling, group therapy, peers, and other types of activities, whether that's meeting with a psychologist or a psychiatrist or other things. But what we do know is that medication does the heavy lifting, and in some cases, medication will treat someone as long as they remain compliant and as long as they're on adequate dose. When we say MAT, we mean naltrexone or Vivitrol is the shot. Naltrexone complete. So think back to the opiate receptor slide. Naltrexone binds to the opiate receptor just like naloxone does. And naltrexone in an injectable form called Vivitrol lasts about a month. So in some cases, that is explained as a protectant, or in some cases erroneously can be told to a patient that you can't overdose if you are on Vivitrol because your receptors are blocked. With high potency fentanyl, you still can. But the thought about using naltrexone is that it takes away the in most cases, ability to get high or euphoric off opioids. And when your brain stops having that experience, typically the desire to use goes down. Switching gears to methadone. Methadone is a full opioid receptor activator. So when methadone's in your system, all the opioid receptors are activated, but it activates them in a sustained way. So it's not get really euphoric, then go into withdrawal. Get really euphoric again, then go into withdrawal. It's a sustained release that keeps your receptors activated so you don't go into withdrawal and so you have less cravings. The problem is you need methadone every day. And typically, historically, you've had to go to the methadone clinic and wait in line with an umbrella like we saw every day. Luckily, there's legislation changes that increase the ability to give take-home doses. So some people only have to go to the clinic once a day, or once a week, or once every other week, or even up to 28 days, take-home medication. And what you might think is, well, all right, well, having 28 doses of methadone in the house, that's pretty dangerous. Interestingly enough, some folks around the country have looked at how the methadone was stored at the house. And for people who are used to going to a clinic every single day, they're pretty darn careful at their house because it makes their life a heck of a lot easier if they only have to go once every 28 days. So in actually greater than half of the cases that have been looked at in a few different studies, the methadone was actually kept in a locked cabinet, which actually is better than probably what most of us do with our regular prescriptions anyway. There's further legislation, which I'll talk about in a little bit. Buprenorphine is kind of the happy medium. So buprenorphine binds onto the opiate receptors, but it only partially activates them. So it binds to your opiate receptors, treats pain a little bit because your opiate receptors are activated, but also blocks opioids from getting onto the receptor. And buprenorphine or Suboxone binds so tightly that it's hard to get knocked off by something else, even fentanyl. So buprenorphine is available in many formulations, Suboxone, Subutex, Zubsolv, but there's an injectable buprenorphine also called Sublocade, which is actually very promising, and I wish it was more available, but it's incredibly expensive and a real hassle to get through insurance in many cases, not all cases. I'll update my software later when we're done. So you might ask, well, that sounds fine, right? Naltrexone or Vivitrol, buprenorphine or Suboxone or Sublocade, methadone. Why isn't everyone on it? Well, there's stigma, of course, which is still a big problem. There's access to treatment or waiting lists or lines to go through, and many others, actually. So you might remember the light bulb picture earlier in the presentation. That's really where our program came about, is that we know these things exist. We know there's great people providing treatment and access to care and medication for addiction treatment, but why can't anyone get there? So when we started talking to outpatient treatment organizations across the state, they told us they have capacity. And that is actually pretty heartbreaking, because there's a whole lot of people that are in the emergency departments or in jails or in prisons or in drug courts that just can't find the people that want to treat them and actually can. So that's why we started the Matters program. And really, we looked at a whole bunch of problems that patients have and tried to create resources that would wrap around them to help them mitigate their obstacles that they face. And boy, does this patient population have a lot of obstacles. So we added things like assistance with transportation, access to medication for patients that didn't have insurance, telehealth options for people who couldn't or wouldn't leave their house. And then also included harm reduction treatment services for patients that weren't totally ready to make the full commitment. We started in the emergency department because that was pretty easy, right? We knew they were doing a horrible job at linking patients to care. But what we also realized is that other places were having a real problem getting people linked up, and that would be inpatient stay. So you're admitted for pneumonia, and it comes out in discussion on hospital day 2 that you have rip-roaring opiate use disorder, and no one ever knew that because you were just using drugs, and now you're in the hospital for your pneumonia, and you can't walk because you're hypoxic, and you're in opiate withdrawal. We get surprised very frequently. Sometimes we're not surprised. Same thing happens with alcohol withdrawal, too. We also have worked to partner with first responders. We know that when people overdose, 911 isn't called all the time, but it is called some of the time, and sometimes people get naloxone and they wake up and they're in withdrawal and they're pissed off, and the ambulance is there, and they say, there's no way in hell you're taking me to the hospital. And after you've heard a lot of this presentation, you're probably not that surprised why they don't want to go to the hospital. So we're working to equip first responders with the ability to link patients to treatment from their living room on our app, which I'll show you how to download for free. So really, it boils down to training healthcare professionals and first responders and drug court officers and prison staff and jail people, sheriff's office staff, to just evaluate people the right way. It doesn't have to be a formal doctor evaluation, just evaluate people. Access to medication. That doesn't mean that everyone has to prescribe medication and then refer them to treatment. So we're fortunate enough to partner with about 80 hospitals and another 80 or so referral locations, whether those are drug courts or prisons or jails or police departments or community outreach teams, homeless outreach teams. And we've built a network of really great treatment organizations across the state. There are about 230 of them. And each one of them chips in a little appointment availability to create a network where patients get to pick where they want to go. So that network, as of today, is about 1,800 appointments a week. So there's quite a bit of capacity for patients to link up. We really want to make sure that patients with substance use disorder and mental health have multiple ways to get into treatment. And what we really want to do is reduce morbidity and mortality rates and offer this service to anywhere in the country. We value quite a few things, but really the bottom line is that we want to partner with people that see the patient as they are. Take them with all their baggage. Don't discount them because they have polysubstance use disorder or a mental health condition or hepatitis. The app is set up on who you are. So if you're someone who needs help, you see resources for you. If you're a healthcare professional, you see resources that would be appropriate for a healthcare professional. There are many different resources that you can access here. The easiest way to do that is just to download the app. So there are some QR codes out front. If you just search Matters Network on the Apple Store or on Google Play, it's super easy. So one other obstacle that I didn't highlight earlier is, why isn't everyone on MAT? Well, because not every healthcare professional is willing to prescribe MAT. That got a little bit easier this year, but also there are healthcare professionals that could prescribe MAT that don't. And part of the reason is that they don't know how, or they're nervous, or they think they're going to get in trouble if they do it the wrong way. So we built a protocol for healthcare professionals that is pretty low threshold, that is safe for most everyone, and that will be effective for many people. And the concept of this is to accompany a referral to a treatment organization so that the patient can get there to their first appointment and get a good assessment and then get linked up and decide what the best long-term or moderate-term care plan is for them. To make a referral is really pretty easy. We ask for a little bit of demographic information. We ask for some other past medical history and past treatment history. If patients don't have insurance, we automatically issue them a medication voucher to cover 2 weeks of buprenorphine for free. We realize that it takes a lot for a patient to come and seek care and tell their story. And if we go through all of that and get over that hurdle and get the trust, link them to an appointment tomorrow, and they get to they get a prescription for buprenorphine, they go to the pharmacy, and turns out their Medicaid is inactive, and they need to cough up $150 to get their medication, the train has derailed. And all of that work is for nothing, because chances are they will get discouraged, they won't go to their appointment, and they will make bad choices. So we knew we needed to change that, and that's why we created the medication voucher program. So thinking about this patient population as a group of people that have been used to being told, sorry, we can't help you. Here's a list of phone numbers that don't work. Hopefully someone will get you in a couple weeks. Now their experience is totally changed. They can look at a map of our clinic partners based on their address that they've typed in a couple slides ago, and they can click on some of the markers and see what the place is, see what type of medication is offered there, and also see what other type of services are offered there beyond opiate use disorder. So they get to pick a place near them. Let's say they're in New York City and they make bad decisions, but they actually live in Utica. From New York City in an ER or at a police station, they can pick a clinic in Utica and go there tomorrow. So our map isn't perfect. There are definitely rural areas that are challenging. We have some telehealth partners that that offer emergency telemedicine evaluations in particularly the rural areas. There is a 24-hour Western New York addiction hotline that can provide assessments 24 hours via telemedicine. That's for the 8 counties of Western New York. There are other parts of the state that we continue to work on, and we have local partners kind of spread out across the state that we work to build those services in those areas. It's not easy. It's not easy at all. We also understand that some patients just can't get to the clinic. So you just click if yes or no. Do you need transportation assistance to your first clinic appointment? As of today, we'll issue instructions for an Uber Health voucher round trip. No questions asked, no waiting, no application, none of that nonsense. We're working to expand the transportation vouchers to other organizations across the state, but also local organizations in pieces of the state, particularly in rural areas where Uber isn't as prevalent. Ever try to open up an Uber app in the middle of the Adirondacks? There's not a ton of cars. The medication vouchers, we've partnered with Walgreens and Wegmans and CVS and Duane Reade downstate to accept our medication vouchers. So you still need a prescription, but the medication voucher acts as payment. And we'll cover up to 2 weeks of medication for buprenorphine. So all the information is sent behind the scenes for healthcare professionals or people working at the jail. They don't have to make any phone calls to make a referral. It's all done electronically, and all this information is sent around behind the scenes. Just a couple slides on steps to take during overdose. I told you earlier, don't worry about figuring out if it's xylazine. Don't do anything different if it may be. You should still call 911. You should still give naloxone. You should still try to wake the person up a couple times, even after giving naloxone, because oftentimes they may be awake but not wide awake. And if that's the case, then they're on the right path. Giving naloxone is very easy. There's 2 doses in each white box that was out front. And you really just peel the label off, stick it in their nose, and push the button. You don't have to prime it. You don't have to worry about giving half. You just give all of it. It's a very small amount of liquid, and it's just like any other nasal spray. You can't mess it up. So just a couple things to wrap this up. What's really being done? So we talked about kind of boots on the ground things about increasing access to treatment, but those things almost like sometimes just feel like, is that really going to make a huge difference, like nationally, if we do this? We need every community to do this stuff, and it's tricky. We went through 100 reasons why it's so challenging. So there are organizations in Washington, D.C., there's organizations spread across the country, but an interesting organization that I thought I would highlight that not many people really know about is the Office of National Drug Control Policy. So this is an office, who's heard of that? Perfect, except you. It's an office that technically sits under the White House umbrella. The director is a physician from West Virginia named Dr. Rahul Gupta, and they help do a couple different things. They help look at drugs coming into the country, another huge problem, which is a separate talk in and of itself, regulation and scheduling of drugs that the DEA does, access to treatment, but then also works on crafting laws that can help access to treatment. So part of that was getting rid of the X waiver to prescribe Suboxone. Part of that is telehealth rules, especially during COVID, rolling back telehealth rules so you could treat patients with opiate use disorder and prescribe Suboxone and have increased access to methadone, which a lot of those have come out of that office. Couple other things in regards to looking at scheduling the fentanyl analogs that we talked about before, how easy it is to change, and then working with other federal organizations like the U.S. Department of Treasury, which you might say, well, what the heck does that have to do with drug use? Well, the Treasury can sanction big, high-level drug dealers and take their money, which is a help, right? All these things, it really takes a pretty sophisticated village to attack all of these different areas, because people who are selling drugs and distributing at a very high level are always a few steps ahead. So education to the public, to first responders, to the medical community, advocacy to work to change laws, trying to push and force change to allow increased access to treatment, such as a bill that is in the House of Representatives right now that would allow pharmacists to dispense methadone and doctors to prescribe methadone. And you go to the pharmacy like any other medication to get your medication, to pick up your methadone. God forbid it would be that easy, right? But I think that it may happen. Just a shout out to my boss, the chairman of emergency medicine at UB. I sent him and Kaylee all the way to Albany on a train to testify in front of the assembly. And here he is with half a smile on his face. So naloxone, as you might have heard, is approved for over-the-counter use. This, come the summer, will be available on shelves at not only the pharmacies, but also gas stations, anywhere that you see Tylenol or Motrin. Yep.
Rumors, you have those on, that I've heard, they're going to charge way too much.
The pricing hasn't been set yet. Although I will tell you, I am afraid whatever they charge will be way too much. So luckily, in a state like New York, naloxone is available for free via many channels. One, you can also request naloxone on our app too. However, to us, this may not seem like a big deal. But to a state like Alabama, the only way to get naloxone is to have someone write you a prescription. So for states like that, this is a huge deal. We talked about the X waiver. The gentleman to the right is a Congress member named Paul Tonko from New York State, and he actually wrote a bill years ago called the X waiver. He knew, and he had a bunch of other folks from Congress support him, and they knew that they needed to get rid of the X waiver, which was an additional 8 to 24 hours of education that healthcare professionals needed to undergo in order to prescribe Suboxone. Guess how many hours of education you need to prescribe Percocet? 0. So luckily, he made it happen, and as of January 1st of this year, you don't need that. That doesn't solve all the problems, though, right? That takes from a couple 100,000 healthcare professionals that had the X waiver that could prescribe to now the 2 million healthcare professionals with prescription privileges in the country can prescribe buprenorphine. Do you think they're all doing it? No. So that's another piece that this is a step in the right direction, but needs constant attention, just like most of the other things that we've talked about today. So what's next? Oh, yeah.
I'm just wondering if there's anything being done at the medical school level to prepare future providers.
Yeah, absolutely. So not only the medical schools, but dental schools, nursing schools, chiropractic schools. We are seeing opioid and appropriate prescribing measures being instituted into medical education at the medical school level, the residency level where residents are being trained, and other ancillary schools, even physical therapy and other kind of wraparound services. So we still need good ideas. We need people to put their heads together and come up with additional ideas, really to find the best idea. And if the best idea isn't found, throwing things against the wall and seeing what sticks, to have other ideas come into place to help reduce barriers to care and increase access to treatment, it was really important. And hopefully you've taken some of that away with you, and maybe you're inspired and you have your own idea, which you should chase. So thank you very much. Please download the app. There's tons of resources out here. Visit with our team. And if you have more questions, you can fire them away now. Thank you.